A transplant was something that years ago we really didn't even consider in follicular lymphoma, and I still do a fair number of transplants in young patients who have relapsed quickly after their first treatment, and we don't like to do it late. You don't want to do it after 2 or 3 or, well, after 3 or 4 treatments for auto. So we have a whole group of diseases that we can really talk about for transplant today. Dr. Henry Fung is the Coleman Professor of Stem Cell Transplant and Cell Therapy. Dr. Sunita Nathan is from Rush, also Assistant Professor of Medicine, and a right-hand person for Dr. Fung, and they do most of this is our lymphoma transplant team, and I think that probably Dr. Fung and Nathan get most of their referrals from the Rush lymphoma team, although they also get referrals from many other centers. Any questions directed to our transplant team? Yes.
Hi, thank you very much for your presentation. It's very informative. Any research I've ever done on allo transplants has always scared me when I'm reading through them. But one of the questions I have is the reduced intensity conditioning. Is that, in your opinion, becoming more of the standard way to do allo transplants, or is that still being done at just select cancer centers throughout the United States?
You guys want to start?
Sure. Well,
Henry, again, just to summarize the difference between an autologous and an allogeneic transplant. Chris made that very clear, but I think it is sometimes confusing, so I'd just like it repeated one more time. An autologous versus an allo.
Autologous stem cell transplant is using the patient's own cells. There will not be any rejections. And what we're doing is we're using very high dose chemotherapy and to overcome the chemotherapy resistance. And this will try to eliminate as many or hopefully all the lymphoma cells in the body. And because this high dose chemotherapy will destroy the bone marrow has stem cells. The stem cells make red cell carrying oxygen, white cell, the immune cell fighting infection platelet. We all need stem cells to live. So we need to extract the stem cells before giving you any patient high-dose chemotherapy, and then we will reinfuse these stem cells. As this is your own cells, there won't be any rejections. Unlike you do a kidney transplant, you do a heart transplant. But then a lot of times, our patient has a deficient immune system, that's why they have lymphoma. And the bone marrow already be damaged. We cannot use the stem cells at all. And also, the immune effect, in particular for follicular lymphoma, are very strong. The donor could be your sister, your brother. They don't have lymphoma. When these new immune cells see these lymphoma cells, they don't like it. So they get rid of it. There's like some fight when you were little with your brother and sister. And sisters always fight, and mother and daughters always fight. Yeah, this is personal experience from my wife and my daughter. Her birthday today, 19 years old, they just fight this morning. I don't know when they will stop, okay. So, but when they fight, this time is good. But when they fight, they can have what we call graft versus host disease, which is something that we all worry about and one of the major hurdles for undergoing allogeneic stem cell transplants. We're talking about back to the question about different types of mini transplant, reduced intensity, myeloablative. Now these are all standard of care. Different patients benefit from different types of transplants. So it is very important to connect with a transplant team when you have follicular lymphoma in particular when they come back. You may not need a transplant, you may not benefit from a transplant this moment, but you need a complete package. At one time, you may benefit from a transplant, and definitely this is a curative intent when we're talking about a transplant. Even autologous stem cell transplant, a few years ago, we already talking about this when an investigator from the Nebraska, City of Hope, and they showed that long-term follow-up patient has follicular lymphoma after autologous stem cell transplant, 10 years, 15 years, when they are disease-free, no lymphoma for 10 to 15 years, highly suspicious that they're cured.
Yes.
Part of your question addressed the role of reduced intensity stem cell transplant currently in the management of follicular lymphoma. And I would tend to agree with the statement that you made in your question that for the majority of patients in the modern era, that reduced intensity conditioning is the conditioning approach that is preferred or utilized. That's in part because of what Dr. Fung said, that for follicular lymphoma in specific and for indolent lymphomas more generally, there is a very potent graft versus lymphoma effect. And many times that's something that can help to eradicate disease even long out after the transplant itself. I'd say the latest that I've seen this occur was when I was in Seattle. We had a patient that was 18 months out of their transplant and still had no evidence that their disease was going away. And at that time, it just started going away and eventually completely went away. So this is when it occurs, and that's obviously a very rare occasion, but when it occurs can be an effect that can happen late after transplant and can be an effect that can be a potent effect and is an effect that can be a permanent effect because you have a new immune system that's out there looking for a fight, as Dr. Fung said, and fighting off those lymphoma cells when and if they come back.
So years ago, we often would say that the role of an allo transplant could be in a patient who perhaps had an auto transplant, and then they relapsed, and then you consider an allo. That's really not done as much, and in fact, at Rush, we actually have a clinical trial looking at a reduced intensity allo transplant at relapse. Dr. Nathan's our principal investigator on that. Could you tell us about that trial? So these patients don't even go to an auto. If they relapse and they're a candidate to go on to a reduced intensity allo, we have a protocol.
So basically, what it looks at is people who have low-grade follicular lymphoma. So it's not necessarily for the patients who have a high-grade disease, because the high-grade disease is a more aggressive form.
But high-grade is a follicular grade 3.
Yes, a follicular grade 3.
It's not staged. She's not talking about stage. She's talking about what they see under the microscope. So she's talking about the follicular lymphomas grade 1 and 2 that the pathologist sees under the microscope.
It also does include the grade 3A patients who behave a little less aggressively than they would if they were grade 3B, where they behave more like the aggressive diffuse large B-cell lymphomas. And essentially in this group, what this study is basically looking at is bringing the allogeneic transplant, that is the donor type transplant, earlier on in the course of the treatment. It utilizes a reduced intensity regimen, or more so a non-myeloablative, meaning we do not wipe out the entire bone marrow with the chemotherapy we give. So it is a more tolerable chemotherapy that is given to facilitate acceptance of the donor cells. That part of the regimen allows patients, it's basically a regimen that patients can get in the outpatient setting. It is as well tolerated. It also uses the higher dose of rituximab, and the primary role of rituximab here is more so to help reduce the one of the adverse effects, or the effects that we see with a donor type transplant, the graft versus host disease, to see if we can limit that and therefore limit the toxicities, if you will, that we talk about with the donor type transplant that everybody is very much concerned about. So the two things this study basically is introducing into the treatment of the lower grade follicular lymphomas is a way to give a much lower dose of chemotherapy, which is better tolerated, and also potentially trying to reduce the development of the graft versus host disease that is problematic, that affects quality of life, that is responsible for the ill effects associated with the transplant, with the morbidity and even the mortality. And that is what we're looking at. It basically goes off the study that Dr. Flowers mentioned, the MD Anderson study, where they used the FCR, or the fludarabine-based regimen, as the basic regimen. It is open to individuals.
Who are candidates for that trial, and the age range also?
It is open to individuals up to 70, even 75 years of age, who are in good performance status. Usually in the transplant group, we look at age as we basically consider age as what is your physiologic age? How functional are you? You could be 75, you could be 80 even, but you could be, functioning as a 60-year-old or even younger, running around with your grandchildren and things like that. And so it all depends on your functional capacity to go through the process. Of course, it requires relatively normal organ function from with respect to the heart, the lungs, the liver, the kidneys, and which is all evaluated. From the disease standpoint, it could be as early as somebody who has had first-line treatment, is in complete remission, and then relapses for the first time and is now presented with the option of a second-line treatment and then the transplant. So it is after first relapse is where the individuals are offered this regimen, because the thought is probably this may be a way to introduce this type of regimen for patients with the intent of cure, of course. That is the goal.
Thank you. Henry, you have said that you are sure that we are going to have a donor for every patient with lymphoma in the future. Why do you say that? And how are we going to do that?
It is my goal or our goals. We have not achieved that yet. But as Dr. Flowers has mentioned, this is really motivated by my own heritage. As you may know, there's one-child policy in China. I'm a Chinese. There's no donors at all. In the past, most donors are from brother and sister. So if there's no donors, then we need to go out and find a donor. So we have the largest unrelated donor registry in the world in America, but there's none in China. So China, in fact, is pioneering mainly in the area called haploidentical transplant. Haploidentical transplant is multiple mismatch, but ending up any parent, any kids can be a potential donor. This is a very active area of development and research. Ending up, when we can do haploidentical transplants, then 99% patient can have a donor. We now launch a program for unrelated donor transplant, as well as haploidentical transplant, mismatched transplant at Rush, focusing on younger patients selected, always selections. But ultimately the goal is hopefully everyone will have a donor when they need a transplant. Doesn't mean everyone need a allogeneic stem cell transplant. In fact, there are many different treatment options, and Dr. Skuster will talk about the new development in the future, bendamustine, and all the other autologous stem cell transplant. It's important to have a comprehensive approach to your lymphoma, because you are the one that has lymphoma, and you are very unique to us.
Thank you. Any other questions? Yes.
I don't have lymphoma, but I have a bad ear. And there was a couple things that went by very quickly. One of them.
It's Dr. Fung.
Right. No, Dr. Gregory, I think this was one that you might have mentioned. Did I hear correctly something about if you had an auto, you can't do an allo later on, or is there?
No. What I said is
that.
that often in the past, if we have talked to our patients about a transplant, it has been an auto transplant using their own bone marrow cells, because we were so concerned about the side effects of an allogeneic transplant. Years ago, when we first started, you have a patient who's going to live years with their disease, they relapse, and you're going to talk to them about a procedure, an allo transplant, which in the past had about a 30% chance of dying just by doing that transplant. Whereas if they didn't do the transplant, maybe they would have lived more years. So now we have refined the allo transplants, and they are less toxic, and we are beginning to offer allo transplants earlier on. What I had said is many of the patients have an auto transplant, they fail that, and then we would have considered an allo. Now we don't necessarily have to put a patient through an auto before they go to an allo.
Okay, so they could do both.
They absolutely. We have to worry about all the long-term side effects of even an auto transplant, because that's why I said you really don't want to do it in someone who's had 3 or 4 prior chemotherapy regimens, because the risk of secondary acute leukemia from the chemo and then from the transplant accelerates. And once you get acute leukemia, as a secondary cancer, most of those patients die within a year. I mean, it's a terrible disease to get from chemotherapy.
And then I had a question for Dr. Flowers as well. That had to do with the purged versus unpurged and exactly what the distinction was there for the stem cells.
Sure, that's a great question. First, I'd like to expand on a little bit on something that Stephanie just said. I think, in years past, as I showed you from some of those survival curves from the IBMTR, that the upfront mortality from allogeneic stem cell transplant was about 30%. Now, with reduced intensity conditioning, at many centers, that is 10% or less than 10%. So that's changed dramatically. And one of the things that I'd like to emphasize is not so much that allogeneic stem cell transplantation is underutilized. You saw that from the curves. But I think one of the things is that discussions of allogeneic stem cell transplant are grossly underutilized. And I think that's something that is very appropriate for many patients to discuss whether or not it's a useful therapy for them or not. And that sometimes gets crossed off the list without even a discussion of it. In terms of the role of purged versus unpurged transplant, to some degree that's a little bit of a historical phenomenon. In years gone by, we've been concerned about the contamination of the stem cells by follicular lymphoma cells that were either circulating in the bloodstream or living in the bone marrow at the time that we were doing the bone marrow harvest. And so the approach in this trial was to do what's called CD34 selection. So to take the cells and then select out the ones that we thought were stem cells or stem cell-like and hopefully leave the lymphoma cells behind. What we found in the modern era is that we don't really need to do that because in effect, with patients who are getting rituximab, with the rituximab circulating in the bloodstream and the lymphoma cells circulating in the bloodstream if they are, and collecting the stem cells through the bloodstream with catheters, we can use the body as a system for what's called in vivo purging, or purging inside of the body so that we can collect stem cells without seeing any of the tumor cells. And in addition to that, what we can do is the flow cytometry test that you heard about from Dr. Call this morning, test the stem cells to see if there are any evidence of lymphoma cells there and prove that there aren't circulating cells. And so purging is a little bit less of a needed phenomenon currently.
So is the Rituxan necessary when you're doing a collection to, so you don't have the purging, so your CD34 cells that you collect are kind of lymphoma-free?
For most institutions, patients either are getting Rituxan around the time of the chemotherapy and that Rituxan is still in the body at the time. What you heard earlier in one of the questions that Brad answered is that for many patients, depending on the number of doses they've had, they still have circulating Rituxan about 3 months out from their last treatment.
Thank you.
Thank you. Any other questions on, are there any patients in the room who have had transplants? Collected? Yeah, but not transplanted. So that's a question that many of my patients ask me. Can we, if my bone marrow is negative for lymphoma, can we collect my stem cells and freeze them away? That would be wonderful, wouldn't it? And I'm going to ask Drs. Flower and Dr. Fung if that's possible.
You want to start? Well, so that is a possible phenomenon. There are a few patients, I would say, that we do on an annual basis who follow that approach. It's something that's probably less commonly done now than it was in years gone by, in part because of some of the therapies that you'll hear about from Dr. Schuster and some of the ones that you heard earlier today that produce so many more options for patients with follicular lymphoma down the line. One of the concerns, at least more of a concern in the distant past, was that if you had a patient with follicular lymphoma that was in remission and you could collect stem cells now, well, what would happen down the line if you can't get them into remission again later, or you can't get a response later? Could you lose that window of opportunity for being able to collect stem cells for a stem cell transplant? With a number of the therapies that we have now, that is a little bit less of an issue, and with some of the concerns that if you don't have sensitive disease, that stem cell transplant is not necessarily an appropriate modality, I would say collecting and storing is less of a common phenomenon. The places where I tend to use it more commonly are in patients who are getting radiation or who are getting some other therapy where you might be concerned that their ability to collect stem cells down the road might be compromised. And in those cases, I'll consider collecting and storing.
So nowadays, with the new stem cell harvest or stem cell collection technique, most patients with lymphoma, we should be able to collect the stem cells. So we would like to collect a lot of people that has early lymphoma, then ending up they would never use it. And when we cannot collect those patients, most likely maybe they should not go for autologous stem cell transplant. We probably have failed multiple regimens already. And we should consider a different treatment approach, including an allogeneic stem cell transplant. So it's not very cost effective, and also the stem cells cannot be staying in the refrigerators for a long time. And
Although they do live.
they do live.
For
Long time,
years.
I mean 10 years, 20 years, that may not be the best thing to do. So as we can do it, we can collect most patients, so we don't do it anymore now.
But the insurance companies don't like us to do this, and that's another issue, that insurance companies rarely will pay for the mobilization of stem cells and the freezing away of them. They usually have to request, we're going forward with a transplant, and that's when the insurance company says, all right, we approve the transplant, and the mobilization is part of that transplant. So that's another issue. Any other questions or comments?
Just one
Chris?
more
Yeah.
comment on that point, and something that Dr. Fung alluded to. Newer technologies, so newer machines for collecting stem cells and newer drugs also have changed this in part. The running joke at our center is that Ned Waller, who's the head of our collection center, can collect stem cells from a stone. And so there are so many newer technologies and newer ways of collecting stem cells now that it's really much less of an issue that you won't be able to collect stem cells when you need them. And so freezing and storing away stem cells. Oftentimes, I've had patients that come for stem cell transplant where we or another center has collected stem cells and stored them away for the transplant, and they're coming in to talk about transplant and moving ahead with autologous stem cell transplant. And we'll say, well, let's try and collect stem cells now, and if we can't collect stem cells, then we'll use your old stem cells. And in most of those situations, we're able to collect stem cells at the time.
It's been a great panel discussion. I'd like to thank our panel again. Thank you very much.